بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. We'll continue the topic of skull-base imaging when we have finished the first part of this talk, which was about the imaging of the anterior skull base. Now we are discussing the imaging of the middle skull base, and this is the most difficult part of the skull base compared to the anterior and posterior one. Then this part is a little bit long, and we will handle it in two parts. The first part will deal mainly with the anatomy and some of the lesions, then we'll continue the rest of the lesions in the second part of this talk. You know that the skull base is divided into three components: the anterior one, the middle one, and the posterior one. The middle skull base is formed mainly by the sphenoid bone, which has two main wings, as you all know, the lesser wing and the greater wing of the sphenoid bone. And also part of the temporal bone is sharing in the middle skull base, including the anterior aspect of the petrous bone and part of the squamous temporal bone. Then this part of the skull base, there are a lot of basal foramina, and here we'll see too many foramina in the middle cranial fossa, and these foramina are very important. They transmit very important structures, and in order to have an idea about this, we can see this video first, then we'll continue the discussion.
So the first foramen we're going to look at is the foramen ovale, which is in the sphenoid bone right here. A little bit posterior to that, we have the foramen spinosum right here, just a small little foramen there. Then medial, we have the foramen lucerum, and lucerum means torn or ragged. Then going back a little bit, we have the carotid canal right here. At the junction between the temporal and the occipital bone, we have the jugular foramen, which is right there. This is the styloid process, and here is the mastoid process, and the foramen that's between the two of them is the stylomastoid foramen. If we look under here, we have a foramen right here, and this is the hypoglossal canal. We have another foramen that's not open on this skull that's called the condylar canal. And right on the roof of the palate by the incisors, we have the incisive foramen. If we turn the skull sideways, we can see that we have the external auditory meatus. And if we look in here, we can see where we have the foramen ovale right here. The foramen rotundum is right here, also coming through the sphenoid bone. Either side of the crystal gala on the ethnoid bone, we have the cribriform plate with the olfactory foramen, a little deteriorated in this specimen. The internal auditory meatus is right here in the temporal bone. And if we take an anterior view, we can see above the orbit of the eye we have the supraorbital notch, and then here we have the infraorbital foramen. On the chin we have the mental foramen here, and then on the inside of the mandible we have the mandibular foramen right here.
Okay, then the sphenoid bone is formed of three parts. The central part, which represents the body of the sphenoid bone. Then we have the greater wing and the lesser wing. Then we have the pterygoid processes, which are projecting inferiorly, as you all know. The sphenoid bone articulates with the cribriform plate of ethmoids through the planum sphenoidale. The posterior to the planum sphenoidale is the tuberculum celli and the sella turcica, of course, the anterior clinoid, which is considered an anatomic landmark that separates the superior orbital fissure, is present here, from the optic canal. And you all know that the optic canal transmits the optic nerve. Then we came to the superior orbital fissure, which is a very important structure in the middle part of the skull base, which communicates the cavernous sinus and the apex of the orbit. It straddled by the tendinous ring here in this particular area. You can see the origin of the extraocular muscles. The superior orbital fissure is bordered medially by the sphenoid bone and superiorly by the lesser wing of the sphenoid, inferiorly by the greater wing of the sphenoid bone, and laterally by the frontal bone. Then, what are the structures going through the superior orbital fissure? We have the three important cranial nerves, the oculomotor, the trochlear, the abducent nerve, as well as the ophthalmic branch of the trigeminal nerve. This is the trigeminal nerve, ophthalmic branch, the maxillary branch, and the mandibular branch. These are the three cranial nerves, the third, the fourth, and the sixth cranial nerves. And this is, of course, the optic nerve, and this is the olfactory nerve. Then the superior orbital fissure serves as a busway for these nerves, as I have mentioned, the oculomotor, the trochlear, the abducent, the ophthalmic branch of the trigeminal nerve, and also the ophthalmic vein. These are some of the foramina we will discuss also. The Vedian canal, which transmits the Vedian nerve and artery. The foramen rotundum, which transmits the maxillary part of the trigeminal nerve. The foramen ovale, which transmits the mandibular branch of the trigeminal nerve. And the foramen spinosum, which transmits the middle meningeal artery. Then this is also a very important space in the middle part of the skull base, which is known as the pterygopalatine fossa. And before showing the anatomy, you have to also to watch this important video, which can explain the anatomy of the pterygopalatine fossa.
Pterygopalatine fossa. This is a small pyramidal space situated deeply below the apex of the orbit. The boundaries are anteriorly superomedial part of the posterior surface of the maxilla, posteriorly root of the pterygoid process and adjoining part of the anterior surface of the greater wing of the sphenoid, medially upper part of the perpendicular plate of the palatine bone. The orbital and sphenoidal processes of the bone also take part. Laterally, the fossa opens into the infratemporal fossa through the pterygomaxillary fissure. Superiorly, under surface of the body of sphenoid. Inferiorly, closed by the pyramidal process of the palatine bone in the angle between the maxilla and the pterygoid process. Communications. Anteriorly, it communicates with the orbit through the medial end of the inferior orbital fissure. Posteriorly, the middle cranial fossa through the foramen rotundum, foramen lacerum through the pterygoid canal, pharynx through the palatovaginal canal. Medially, with the nose, through the sphenopalatine foramen. laterally with the infratemporal fossa through the pterygomaxillary fissure, inferiorly with the oral cavity through the palatine canal. Contents. Third part of the maxillary artery and its branches, which bear the same names as the branches of the pterygopalatine ganglion and accompany all of them. Maxillary nerve and its two branches, which are zygomatic and posterior superior alveolar. Pterygopalatine ganglion and its numerous branches containing fibers of the maxillary nerve mixed with autonomic nerves.
And then we have to look at the anatomic details of the pterygopalatine fossa from the radiology point of view. Medially, as you have listened before, the pterygopalatine fossa communicates with the nasal cavity through the sphenopalatine foramen, and this is the area where the sphenopalatine foramen is present. And laterally, the pterygopalatine fossa communicates with the infratemporal fossa, and this is the infratemporal fossa, as you all know, through the pterygomaxillary fissure. Anteriorly, it communicates with the orbit through the inferior orbital fissure. I will show it in a moment. And posteriorly, the pterygopalatine fossa communicates with Meckel's cave and the cavernous sinus through the foramen rotundum. Then these are the important anatomic landmarks in the middle cranial fossa. And here you can see the site of the pterygopalatine fossa between the apex of the maxillary sinus and the root of the pterygoid bone. Of course, you know that this is the pterygoid body, lateral pterygoid plate and medial pterygoid plate, and the fossa in between is the pterygoid fossa. And this is the pterygomaxillary fissure, which connects the pterygopalatine fossa to the infratemporal fossa. Then here is the pterygoid canal, which is also known as the Vedian canal, where the Vedian nerve is crossing as well as the Vedian artery. I will show it immediately now. And this is the remaining part of the pterygopalatine fossa. As you remember, it communicates with the orbit through the inferior orbital fissure, as I have mentioned before. Then here is the close view of the orbit showing the superior orbital fissure and the inferior orbital fissure, and this is the optic nerve canal. And if you have axial sections in the skull, you will first see the inferior orbital fissure. Then in the second section, you'll see the space which is communicating the inferior orbital fissure to the superior orbital fissure. In the third image, then you'll see this is the site of the superior orbital fissure, and many times you can see here the optic nerve canal medial to it. Then in the coronal images, you can easily appreciate the superior and inferior orbital fissures. This is the orbital apex, and here is the superior orbital fissure, and here is the inferior orbital fissure. Through the inferior orbital fissure, there is the infraorbital nerve, the zygomatic nerve, branch of the inferior ophthalmic vein, and the infraorbital artery. These are the structures crossing through the inferior orbital fissure. Then a part of the middle cranial fossa is the sphenoid bone, and this is the body of the sphenoid, as you can see here. And this is the also the body of the sphenoid, showing the greater wing of the sphenoid as well, which is forming part of the anterior aspect of the middle cranial fossa against the temporal lobe of the brain, as well as part of the lateral orbital wall. And here you can see two important foramina in the middle part of the skull base, which are the Vedian canal, which transmits the Vedian nerve, and this is the Vedian canal. And adjacent to it immediately, you can see the foramen rotundum, which transmits the maxillary branch of the trigeminal nerve. And here they are best appreciated in the coronal image rather than in the axial images. They are very close to each other. This is the Vedian canal, and this is the foramen rotundum. The Vedian canal is also known as the pterygoid canal. It can be seen in the axial images and also can be clearly identified in the coronal plane, where you can see this is the foramen spinosum and this is the foramen ovale, and medial to it you can see the Vedian canal or the pterygoid canal. And here, this is the pterygopalatine fossa, as you remember, connected to the orbit through the inferior orbital fissure. And this is the pterygoid canal or the Vedian canal, which is passing posteriorly. And this is the foramen lacerum, and this is the pterygo-occipital fissure, and this is the jugular foramen. This part will be discussed in the sector of the posterior skull base. Then here you can see this is the sphenoid sinus, and this is the optic canal. Here you can see the two important foramina, the Vedian canal and the foramen rotundum. Here you can see the lateral pterygoid blade, the medial pterygoid blade, and the pterygoid fossa as well. The foramen lacerum is a triangular space located in the middle cranial fossa anterior to the apex of the petrous bone. This is the accurate site of the foramen lacerum, which measures about 9 millimeter in length and 7 millimeter in breadth. This foramen lacerum is filled by connective tissue and transmits small meningeal branches of the ascending pharyngeal artery and some of the veins. The internal carotid artery does not pass through the foramen lacerum, but it passes superior to the lacerum, to the foramen itself. Then these arrows points to the foramen spinosum, and this is the foramen ovale. The foramen ovale transmits these structures, when you can remember, by the letters of ovale. O stands for the otic ganglion, and V for the third branch, or the third branch of the trigeminal nerve, which is the mandibular division, then accessory meningeal artery, lesser petrosal nerve, and some of the emissary veins. This is the foramen ovale in the axial images, which can be easily appreciated, and this is the site of the foramen ovale in the coronal images. Then the foramen rotundum is very close to the inferior orbital fissure and also very close to the Vedian canal. This foramen rotundum transmits the second branch of the trigeminal nerve, which is the maxillary branch. It is better appreciated in the coronal plane rather than in the axial plane. This is, as you remember, the foramen ovale, and this is the Vedian canal or the pterygoid canal. Then this arrow points to the foramen spinosum, and this foramen transmits the middle meningeal artery, the middle meningeal vein, and some nerves, the nerve which is known as the nervus spinosus. Then this foramen is very small and located posterolateral to the foramen ovale. Then we have these important structures in the skull base, in the middle cranial fossa, including the tuberculum celli, the sella turcica, the pterygopalatine fossa, the foramen rotundum, the Vedian canal, the foramen ovale, the foramen spinosum, the anterior clinoids, the optic canal, the superior orbital fissure. The carotid canal will be discussed in the posterior skull base, and we have discussed already the foramen lacerum. Then we came to the lesions affecting the middle skull base, and we will start as we started in the anterior skull base by the congenital lesions like encephalocele, then the fractures and CSF leaks. Then we have three important issues in this part. Lesions coming from above invading the skull base, and these are the cellular, paracellular lesions, and maybe the sphenoidal sinus lesions as well. And lesions coming from below, invading the skull base, and these are the nasopharyngeal pathology. Then we have some lesions dedicated to the skull base, like the deposits, the chordoma, and the meningioma of the skull base. Also, we have Paget disease as well as the fibrous dysplasia. And fractures of the skull base has been also discussed in have been also discussed in the anterior cranial fossa, and we discussed the issue of cribriform plate ruptures and the CSF rhinorrhea. And here we also continue with this fractures which now involve the paranasal sinuses, especially the sphenoid sinus, which is the major component of the middle cranial fossa. Of course, fractures of the petrous bone will be discussed in the posterior skull base. And here you remember the Lefort fractures, which involve the pterygoid plates as well as part of the facial bones, depending on the type of the Lefort fracture. We have discussed this in details in the sector of maxillofacial injuries. And this is the remaining uh, uh, elements of the Lefort fracture affecting the anterior wall of the maxilla, the posterolateral wall, the zygomatic arch, the frontal sinuses, the sphenoid sinus, and maybe part of the zygoma as well. In the coronal images, you can see fractures of the sphenoid sinus with the hemosinus, opacification of the sinus by blood. Then you can see fractures of the pterygoid blades, the comminution of the orbital roof, as well as the ethmoidal air cells, and also the frontal bone. You can see some of the intracranial displaced comminuted bone fragments, surgical emphysema due to injury of the maxillary sinus as well. Then we came to the lesions coming from above, invading the skull base, which are mainly located in the sella and paracellar area. You remember we discussed this issue before, the pituitary adenoma, the micro, the macro, and we mentioned some words about the invasive pituitary adenoma. Then we'll discuss paracellar meningioma and trigeminal neuroma, paracellar chordoma and paracellar chordoma and chondrosarcoma, rhabdomyosarcoma, and also we'll discuss the perineural tumor spread. And if you see a mass inside the cella, and this is first of all, it will represent a pituitary macroadenoma. And this adenoma will extend in the supracellular cistern, obliterating the cistern, compressing the chiasm, and maybe also the hypothalamus. And this is what we call regular adenoma. But if the adenoma has destroyed the cellar floor, invaded the sphenoid sinus, and at that time we should call it invasive pituitary adenoma. And this is a very good example of invasive pituitary adenoma. And you see a mass involving the cella with supracellular extension, and also you have a very large part destroying the skull base and protruding into the nasopharynx. This is an invasive pituitary adenoma. This is the difference between regular adenoma, where the adenoma is respecting the cellular floor, it extends in the supracellular cistern and may compress the chiasm as well as the hypothalamus. But this is the invasive pituitary adenoma, which besides extension into the supracellular area, it invades the skull base and destroys the sphenoid sinus and may bulge into the nasopharynx as you have seen before. And this is invasive pituitary adenoma, and invasive pituitary adenoma involving the cella with a big suprasellar extension compressing the hypothalamus, as well as invasion of the sphenoid sinus, which is almost totally obliterated by the tumor. And the tumor shows homogeneous post-contrast enhancement, and you can see the relation of the lesion to the carotid arteries with a possible invasion of the right cavernous sinus, because you can see some of the enhancing tumor tissue lateral to the carotid artery, which is considered one of the major signs of cavernous sinus invasion. Another example of invasive pituitary adenoma with suprasellar extension, invasion of the sphenoid sinus, and maybe destruction of the skull base, including erosion of a part of the clivus, as you can see here. This is invasive pituitary adenoma that has infiltrated the sphenoid sinus and also infiltrated the right cavernous sinus with evident tumor tissue lateral to the carotid artery, indicating cavernous sinus invasion. And this arrow points to the optic chiasm, which is touched by the lesion, as you can see here. Then meningioma in the paracellular area is one of the well-known locations for the meningioma, and the appearance of meningioma in this area almost simulate the appearance of meningioma anywhere intracranial. Then meningioma in this particular area can involve the skull base and can extend extracranially through the skull base foramina. And these are the sites of meningioma in the skull base. Remember that meningioma is one of the tumors commonly seen anywhere in the skull base, anterior, middle, and posterior. Then we have olfactory groove meningioma in the anterior cranial fossa, tuberculum celli, sphenoid wing, cavernous sinus, petroclival, and these are in the middle cranial fossa, jugular foramen meningioma, foramen magnum meningioma in the posterior skull base. Then paracellular meningioma can involve the cavernous sinus and produce symptoms of cavernous sinus invasion with affection of the cranial nerves passing through the sinus. Meningioma may have an osteoblastic reaction with hyperostosis, which is evident in this area because of the relation of the tumor to the very small bones in the skull base. And meningiomas are almost isointense in the T1 and T2. They show homogeneous, intense enhancement after contrast injection. And some of the areas which are not enhancing through the tumor may represent the signal void vessels of the tumor, focal areas of calcification, small areas of necrosis or cystic changes, or entrapped CSF spaces. And you remember the CSF cleft sign, which is one of the important signs to diagnose extraaxial lesions. This is an example of a paracellular meningioma. You see the homogeneously enhanced lesion to the left of the cella, which is most likely invading the cavernous sinus. By MRI, meningiomas usually show diffusion restriction because of the cellularity. Here you can see minimal restriction, and this is T1, this is T2, and this is T1 post contrast. And here is the FLAIR image, and you can see evident enhancement, which is homogeneous in this paracellular meningioma or the clinoidal meningioma, and you can see here. And this is a skull-based meningioma, which is considered one of the lesions centered between the middle and the posterior cranial fossa. It has destroyed a significant part of the petrous bone. The lesion showed homogeneous, strong enhancement, as you can see. And paracellular meningiomas are frequently seen in the clinical practice. They usually invade the cavernous sinus. They can extend also into the orbit, and maybe it can extend through the skull base in the extracranial space. Meningiomas will show intermediate signal in the T1 and T2 weighted images, so significant contrast enhancement and dural tail, as you remember. This is one of the, let's say, aggressive meningiomas, which destroyed the skull base and invaded the cavernous sinus, totally encasing the internal carotid artery, which is still patent. As you can see, it's a normal signal void. There is invasion of the ethmoidal air cells, invasion of the orbital apex, and in the coronal image, you can see invasion of the skull base with extracranial extension. Of course, anyone cannot imagine that this may represent a meningioma. It may represent a rhabdomyosarcoma or a skull base metastasis or any of the aggressive lesions, but this was biopsy proven to be a skull base meningioma. And meningioma can be confined to the intracranial space, and in this particular area, it may invade the skull base or may involve the skull base with extracranial extension. And this is another example. You see the dumbbell configuration of the lesion in the cerebellopontine angle in the paracellular area. This lesion can be easily mistaken for a trigeminal neuroma, for example. But we'll discuss the trigeminal neuroma later on, and we'll show how can you easily differentiate between meningioma and the trigeminal neuroma. This is another example of a meningioma, or I think the same example we have seen before, with infratemporal extension and extension outside the cranium. Then we came to the trigeminal schwannoma, and you know that schwannomas or neurofibromas represent about 6 to 8% of intracranial neoplasms. The most common is the acoustic neuroma, followed by the trigeminal and then the facial neuroma. The trigeminal neuroma is an encapsulated tumor infiltrating the third division of the trigeminal nerve, where this usually occurs in the third and fourth or to the fourth decades. It appeared as the cerebellopontine angle lesion or a paracellular lesion or a dumbbell shaped lesion with a paracellular component and cerebellopontine angle component. If this lesion is seen in younger patients and if it is multiple, then you may consider the possibility of neurofibromatosis type. Then you remember that schwannomas are characterized by the presence of areas of cystic degeneration, which may occur in about 60% of the lesions. And here you see an enhancing mass, which is having a dumbbell configuration, a paracellular component, and the cerebellopontine angle component. Then one of the differentiating points between trigeminal schwannoma and meningioma is the cystic component. This cystic component is different from the cystic component associated with the meningioma, which is not usually seen in the meningioma occurring in the paracellular or the cerebellopontine angle lesion. Then one of the differentiating points also, and you know that the trigeminal schwannoma arises from the trigeminal nerve ganglion, which is located in the Meckel's cave, which is located posterior to the cavernous sinus. Then the ganglion of the nerve will appear as a low signal structure in the back of the cavernous sinus. And if you fail to detect the trigeminal neuroma in the presence to detect the trigeminal ganglion in the presence of such a mass. This is an indication that the mass is originating from the ganglion. But if you see an enhancing lesion and you can easily identify the ganglion, then consider other possibility for the trigeminal for the other than trigeminal neuron. Calcification and hemorrhage are rare in the trigeminal schwannoma, but atrophy of the masticator muscles with fatty infiltration can be seen because of the involvement of the trigeminal nerve, and the treatment is, of course, by surgical excision. Then one of the signs also of to differentiate trigeminal schwannoma from a meningioma is the widening of the foramen ovale. You know that the foramen ovale transmits the third division of the trigeminal nerve, and this lesion may extend extracranial through the foramen, and you can compare the size of the normal foramen by this markedly widened foramen with intact smooth margin, and this is the normal appearance of the foramen ovale on both sides. An example of trigeminal schwannoma by MRI T2 and T1 post contrast with a good part of the cystic component of the tumor showing mixed signal intensities as well as a solid component showing homogeneous enhancement. And this is another example of trigeminal schwannoma with paracellular location and a small component in the cerebellopontine angle. And you can see the intimate relation of the tumor to the carotid artery. Also, the meningioma in the paracellular area will encase the artery, and it may reduce its caliber, while the trigeminal schwannoma will not do this. It will displace the artery medially. And if you see a lesion which is located at the site of the trigeminal neuroma, and this lesion has an aggressive characters, one of the diagnostic possibilities is that to be a malignant form of the trigeminal neuroma. And you know, this is known as malignant peripheral nerve sheath tumor. But still, the tumors in the pharynx invading the skull base is in the differential diagnosis. Metastasis to the skull base, lymphoma of the skull base, meningioma with aggressive characters, all these can be included in the differential diagnosis. And paracellular aneurysms arise from the intracavernous part of the carotid artery, and they are one of the lesions included in the differential diagnosis of a paracellular mass. And these lesions are characterized by their flow and the artifacts originating in MRI due to turbulence of the flow inside the aneurysm itself. If you have the CT, and you can see some calcification, and you may see also some erosive changes of the adjacent bone. In MRI, there may be, as written in the literature, that pneumatization of the anterior clinoid or calcification post-produced signal void can simulate an aneurysm in this area. But of course, the MR angiogram or the CT angiogram can easily reach the diagnosis. And here you can see the lesion in the left paracellular area with the characteristic whorly appearance, especially on T2 weighted image, which indicates the presence of an aneurysm that has been confirmed by MR angiogram. This is bilateral aneurysms in the paracellular area. Both showed the characteristic whorly and some signal void appearance. And in the angiogram, you can see both of the aneurysms. another case of an left paracellular aneurysm, and the coronal T2 weighted image, MR angiography, and DSA aided selective and carotid angiogram, and see the big aneurysm in the paracellular area. And skull-base chondrosarcoma is a well-known tumor of the head and the neck, and it represents about 7% of the head and neck chondrosarcoma. And chondrosarcoma may be predisposed by the presence of Ollier or Mahfouz syndrome, and also the presence of previous fractures. This is the common site for the origin of skull-base chondrosarcoma, the vitro-occipital synchondrosis, and this is the suture between the vitreous and uh, the sphenoid bone, or it's known as the spheno-occipital or the vitro-occipital synchondrosis, also the sphenoethmoidal junction, and inside the cell letters. Here are the sites of chondrosarcoma. You know, chondrosarcoma is located off the midline, while chordoma is located in the midline. But you know that chordoma can occur in the paracellular area, and also chondrosarcoma can occur in the midline, and there is a good overlapping criteria between both the chordoma and the chondrosarcoma. Then, if you see a lesion like this by MRI, and it gets an enhancing lesion in the left paracellular area, in the right paracellular area that has infiltrated the right cavernous sinus, displacing the carotid artery posteriorly, then this lesion will be included in the differential diagnosis of many of the lesions, like the paracellular meningioma, paracellular trigeminal neuroma, and paracellular chordoma, paracellular chondrosarcoma, paracellular metastasis, and these are all can be included in the differential diagnosis. An area lesion which is diagnosed as chondrosarcoma in the right paracellular area, and you see the lesion is encasing infiltrating the cavernous sinus, encasing the internal carotid artery, which is more or less patent. And remember that chondrosarcoma and chordoma, because of the presence of chondroid matrix, they may show very bright signal in the T2 weighted image, almost reaching the signal of CSF. Then if you look at the T2 weighted image, you may imagine that this is a cystic lesion, but in the T1 weighted image, the lesion will appear solid, and if you inject contrast, it will show significant post-contrast enhancement. And this is what I am saying, that the tumor will appear solid in the T1 weighted image, and the T2 weighted image, the lesion is very bright, almost similar to the CSF, and after you inject contrast material, it will enhance significantly, as we can see here. This is one of the helpful diagnostic criteria of chordoma and chondrosarcoma, the chondroid matrix, which show very bright signal in the T2 weighted image. Then the presence of matrix calcification also helps in the differential diagnosis, but these calcification are better evaluated, of course, by CT, where you can see it. This is a paracellular lesion with dense matrix calcification seen in even in the bone window. Images are obtained for an angiogram, and the presence of these calcium will help in the differential diagnosis. And the differential diagnosis of chondrosarcoma will include the atypical meningioma and the trigeminal schwannoma, hemangiopericytoma, cavernous hemangioma, chondroma and chondrosarcoma of the clivus. Then here you see a lesion. This is the lesion which has been seen previously by CT containing matrix calcification. On MRI, the tumor is enhancing. Of course, you cannot appreciate the presence of calcium here, but the the location of the lesion is in the paracellular area, and it may be included in the differential diagnosis that has been previously mentioned, but the presence of calcium will limit the differential diagnosis in such a case. And here, a chondrosarcoma of the skull base infiltrating the sphenoid sinus, infiltrating the paracellular area, and extending into the extracranially in the nasopharyngeal area. Then this lesion in the T2 weighted image shows significant bright signal, which is one of the, as I have said, helpful to suspect the possibility of chondrosarcoma. Then we came to the rhabdomyosarcoma, and this tumor is commonly seen in children, as is considered the most common soft tissue sarcoma in the pediatric age group. It represents about 40% of the lesions in the head and the neck, with a peak of incidence around 2.5 years of age, and most of the lesions, up to 80, even 80%, are seen under the age of 12. This tumor is not originating from the striated muscles, but its histological appearance is similar to the striated muscle, and hence the name. Because this tumor, as I have mentioned in the lecture of soft tissue tumors, is this rhabdomyosarcoma can occur at certain anatomic sites where no skeletal muscles are present. Then this lesion may metastasize to the lymph nodes, to the lung, to the bone. It is seen in the head and neck, usually in the nasopharynx, but can be seen also in the orbit and in many other places. Its imaging findings are usually non-specific, but we depend on the age of the patient and the location of the lesion to reach the diagnosis. Then the common locations include the orbit, the nasopharynx, the sinuses, paranasal sinuses, and the tumor can, of course, invade the brain or extend intracranially in about 41% of the cases, and metastases are frequent. In the imaging, you have non-specific finding of a large, infiltrating, enhancing soft tissue mass with aggressive bone destruction, intracranial extension, and it has no specific signal intensity and no specific contrast enhancement. And this is a female child, 10 years old, with a mass infiltrating the skull base with a component intracranial and another component extracranial, low signal in the T1, high signal in the T2, and the heterogeneous post-contrast enhancement. Because of the age of the patient, we can suspect the possibility of rhabdomyosarcoma, but of course, skull base lymphoma and metastases can be included in the differential diagnosis. And this is a female child, 7 years old, with a big mass in the nasopharynx eroding through the skull base, and this was a rhabdomyosarcoma. The MRI of the same case showed a mass with an intracranial component and extracranial component, with low signal in the T1, high signal in the T2, heterogeneous post-contrast enhancement. And this is a child to 10 years old with a mass in the nasopharynx, when also infiltrating the pterygoid muscles and infratemporal fossa, with extracranial extension through the skull base into the infratemporal fossa. Then after contrast injection, you see intense, almost homogeneous post-contrast enhancement. Another case of a male child, 6 years old, and here you see a big mass obliterating the nasopharynx, the posterior nares encroaching on the parapharyngeal fat, destroying the sphenoid sinus as well as the posterior ethmoidal air cells. And of course, this may represent in rhabdomyosarcoma, lymphoma, metastasis, the same list of the differential diagnosis. And this is the MRI of the same case. You can see in the T1 the tumor is iso-intense to the muscles. In the T2 there is a slight increase in the signal with evident post-contrast enhancement destroying the skull base, the sphenoid sinus, and the ethmoidal air cells with a good part of the mass bulging into the nasopharynx. In rhabdomyosarcoma, in differential diagnosis include in the pediatric age group, of course, you may be confused with the nasopharyngeal angiofibroma, sarcoma, lymphoma, and sometimes squamous cell carcinoma. In adults, the same differential diagnosis also include lymphoma and carcinoma, as well as metastasis, of course. There may be some of the inflammatory lesions which may produce masses involving the skull base like sarcoid and TB and fungal infection, but the main differential diagnosis will include lymphoma, carcinoma, and metastasis. Thank you very much. Walhamdulillahi Rabbil Alameen.